Hello, my name is Ankita Dubey and I'm a second year internal medicine resident at Extension Providence Hospital, and today we will be presenting a rare case of patent ductus arteriosus in a young postpartum woman, and we have no relevant financial relationship. Patent ductus arteriosus is a rare congenital heart anomaly. It accounts for 5 to 10% of all congenital heart diseases. Normally, ductus arteriosus spontaneously closes at birth. Persistent patent ductus arteriosus has been rarely found or described in adults. Today we present a case of a young woman presenting with immediate postpartum symptomatic PDA. So we have a 25-year-old multigravida woman who presented to the emergency department on postoperative day 7 following a cesarean section with chief complaint dyspnea. On presentation, the patient was found to be afebrile with heart rate of 66, respiratory rate of 27 breaths per minute, blood pressure of 172/92, and she was saturating 100% on room air. Physical examination was positive for a grade 3/6 continuous murmur heard in the second intercostal space. A transthoracic echocardiogram was obtained which demonstrated a large PDA connecting the aorta to the pulmonary artery. The echocardiogram images obtained are shown below. Figure 1A is a suprasternal view indicating the patent ductus arteriosus or connection between the aorta and the pulmonary artery as labeled. The color flow shows the jet or the blood flow between the aorta and the pulmonary artery. Figure 1B is similar suprasternal view with a color flow Doppler showing the connection between the aorta and the pulmonary artery through patent ductus arteriosus. And figure 1C is a Doppler assessment of the connection between the aorta and the pulmonary artery, which shows the shunting is left to right. So most of the Doppler velocities are above the baseline, indicating the blood flow moving towards the probe. In terms of discussion, our patient presented here with postpartum decompensated heart failure and was found to have a large persistent patent ductus arteriosus. With a chief complaint of dyspnea, we also obtained a CT angiogram to rule out other pathologies such as pulmonary embolism, which was negative. Our patient also presented with blood pressure of 172/92, so she was managed with blood pressure control with nifedipine and labetalol, and she was also given IV diuresis to control her volume overload. Her symptoms improved, and she was then provided a follow-up with congenital heart disease clinic for a patent ductus arteriosus closure. Our case highlights the importance of keeping intracardiac shunting in the differential diagnosis for unexplained etiology of heart failure in postpartum patients. So in conclusion, our case highlights the multidisciplinary approach to care of adults with congenital heart disease. It also highlights the importance of early cardiac screening during the antenatal period to prevent morbidity and mortality among pregnant and postpartum women. Thank you very much for your time and listening to us.